Please, everybody, when you're asking questions, introduce yourself and the hospital you work at and proceed. Thank you.
My name is Hussein Khalid. I am a professor of medical oncology, vice president of Cairo University in Egypt. I have a comment for Dr. Alexander Inu and a question for Dr. Nagi Saghir. For Dr. Inu, I disagree. I think that there is a must that medical oncologists must be present whenever chemotherapy or systemic therapy is given. It is not only the side effects of the drugs, it is dealing with a patient as an internal medicine specialist, having heart failure, liver failure, respiratory failure, other complications that needs the need for a real medical oncologist. Maybe the medical oncologist would be helped by a subgroup of associates that are trained for a short period of time, but there must be a medical oncologist whenever we treat patients with systemic therapy. The question of Dr. Nagi is about, you mentioned about 319 participants in this study. What was the distribution of these participants on the countries? Because if the percent is a majority in one or two countries, then it would not reflect the whole region. Thank you.
Alex, go ahead.
So I understand your comment, and I was thinking about that. The idea is that reality is different. Reality is that patient care is taking place in countries where medical oncologists do not exist. And simply put, if you require to have a medical oncologist, then a lot of people will die. So what I'm suggesting is not that medical oncologists can be replaced by anybody, but I do believe as we stratified our recommendations for low-resource countries, where you don't have medical oncologists that you've seen in the difference in the low number of medical workers in those countries. So I would say that for low-resource countries, you could think of a smaller course on specialization. You could think of trying to train whoever is interested in performing systemic therapy for breast cancer patients, be it a surgeon, be it a radiation therapist, be it an internal medicine specialist. I do believe you can try and train him for a limited amount of techniques or management so that actually you're moving forward. If you say, because in Ghana there's no medical oncology training, period.
I'm Larry Schulman. I'm a medical oncologist from the Dana-Farber in Boston, and we work with 2 sites in Africa and with Haiti. And I would agree with the speaker. I think if you require a medical oncologist to be on site, a large proportion of the world will not benefit from therapy. There just aren't enough of us to go around, and so I don't think that's an acceptable solution. We do administer chemotherapy at all 3 of our sites without medical oncologists, with the backup of the medical oncologists from the Dana-Farber, who are available 24/7. We do have very, very detailed instructions for preparation and administration and toxicity management, and we've monitored our ability to give chemotherapy safely and with good outcomes at those 3 sites, and I think we've done very well. I'm going to talk a little bit about this on Friday, but I agree with your last comments. The practicality is that if we require medical oncologists, we deny a lot of the world care.
So I am Dr. Navneet, and I am working in a university hospital in Delhi, India. And I would like to contribute to the discussion on being given chemotherapy by general physicians. In my hospital for last 10 or 12 years, it was being done by the surgical team itself, and it can be nicely done. But there are few handicaps because of which we really cannot deliver service at par with the trained medical oncologist. One thing being, for a surgical team, giving chemotherapy is not a priority. So after the surgical work is done, then only the patient gets attention to receive chemotherapy. And also, The protocols may not be standardized because there is a lot of inter-team variation. So if one surgical team may be giving in a certain manner, the other team would be giving in a certain manner. So though it is practically feasible, we did it for last 12 years, till the time we had a center coming up next to our hospital. But the standard of care, I'm sure, is not addressed as much as if the chemotherapy is being given by a trained medical oncologist. Thank you.
Yeah, I just wanted to, I'm Joe Harford from the NCI. I just wanted to clarify one point that was made in the introduction by Alex, and that is when he was looking at the burden of disease versus healthcare workers, and it sort of relates to this. Those figures from WHO are for all health issues combined, and the healthcare workers are for all health issues combined. It certainly is not the case that the burden of breast cancer is higher in Africa than it is in the United States. But in the case of the healthcare workers, and this relates to the topic at hand, I would suspect that the African healthcare worker number is actually overblown when it comes to, there's no data on how many cancer docs or oncologists or anything like that there are, but certainly probably the disparity is even worse than you're showing in terms of cancer docs.
Yes, go ahead, Dr.
Thank you, Dr. Samia Al-Amoudi from Saudi Arabia. Well, I'm a doctor and I'm a breast cancer survivor as well. If you give me the choice, definitely I will choose to have my chemotherapy with oncologist. But if I don't have that choice, then the situation is different. Let me tell you about our experience in Saudi Arabia as gynecologists. In the 80s, until recently, maybe 5-7 years ago, we did not used to have oncologists in our department. And I'm sure that happens everywhere, that the oncologists were the one who are taking over with the oncology from the chemotherapy aspect. Chemotherapy is totally different than surgery. Nobody can replace the surgeon. But for chemotherapy, those who are trained in medicine or medical treatment, they can cope to a certain extent. The other thing is the technology now is totally different. Even in a rural area, through the internet, they can revise the protocol, they can revise the doses. So there are ways to overcome the obstacles instead of saying, no, these people cannot practice chemotherapy. Thank you so much.
Sounds like we'll have to pack.